for the introduction. Thank you everybody for joining us today as we kickstart our Mastering IMRT for Physics course. And thank you to RCC for organizing and putting everything together. The outline of our 1 hour or about 1 hour session is going to be a bit of an introductory. So I'll introduce what's being covered in the course. Feel free to post any questions as they come up in the chat. And I just want to let the moderators know that I'll take little breaks throughout the talk, and that'll be a good time to bring up any questions, and I'll take a look myself at the chat. The second part of our lecture is going to be on shielding for linear accelerators, and in particular for IMRT. I'll talk about some of the important concepts. NCRP 151 are the guidelines that we follow here, and those are the ones that I'm going to go over. And we'll walk through some examples of how to perform Linac shield calculations. All right, what is covered in this course? So here is the same list of sessions that Ben showed earlier. We are over here in the introductory session and the first topic, which is shielding survey. And as you can see, we're going to cover things like dose calculation algorithms, such as Monte Carlo, and how to choose the appropriate detector for a particular task and the consequences, validating a commissioned treatment planning system, and performing patient-specific QA, and many other ones. I think these are great topics, and they are very important to a successful IMRT program at your cancer center. And I guess I'd like to begin by asking all of the attendees, and maybe this can be the first poll question that we put up, if you guys could help me with that, moderators. But I want to know which topic you're most excited about for this course as we begin this 16-week journey together. Is it modeling and commissioning, patient-specific QA? Is it shielding calculation, treatment planning? Or are you most curious about, detectors, ion chambers, when you're making patient-specific QA measurements? Do you want to know about your detector and which one is appropriate for a particular plan and which one is not? Totally. So it looks like we have about 50% for treatment planning and then about 30% for TPS modeling and commissioning.
Yeah, we'll share the results once I click the end poll button.
Got it. Yes, I do see them coming in.
Okay.
So should I press the end poll button?
I'll push it. So yeah, it looks like the results have.
Awesome. Okay. So the first thing I'd like to say is I'm not taking it personally that shielding survey is the lowest one, but treatment planning, totally very important. I agree. And commissioning and modeling. Okay. So those are some good things to keep in mind. And we have multiple sessions on treatment planning and multiple sessions on aspects of commissioning and TPS modeling. So I think you're going to get a lot of that, and also patient-specific QA. And I mean, underlying everything there is making dose measurements and the detectors that we're using. So can I close this? Is that possible? Yeah. Great. All right, so let's jump into our intro for IMRT. We're talking about intensity modulated radiation therapy. So this is an advanced form of 3D conformal radiation therapy. And the advanced part is that we can better conform the dose around the tumor, which allows us to reduce dose to healthy tissue. And really, IMRT is a result of technological advancements in our ability to shape the radiation field with our linear accelerators and also deliver radiation from different gantry angles. And this will result in the ability to deliver more dose to the tumor and less to healthy surrounding tissue to better outcomes in terms of life expectation and quality of life. Reduced repeated treatments. So a lot of times we can either miss the tumor or sometimes have adverse events that require the patient to be treated repeatedly. Also, much fewer side effects and reduced burden to the healthcare system. So all of this is really important. And it all comes as a result of our ability to modulate fields. And there are various ways that we can modulate fields, such as compensator based, which were very common back in the day. But then it was really these and the advancements of multi-leaf collimators that allows us to perform these various forms of field modulations. And I'll just talk about a couple of versions, but we have several kinds. We can even go into the advanced, maybe more treatment site-specific machines, such as helical tomotherapy, CyberKnife. Those are very specialized linear accelerators, but it essentially performs the same thing. So multi-leaf collimators, so MLCs. I'm not going to go into the technical aspects of MLCs. That is going to be left for another session. You guys will talk about different kinds and thicknesses and sizes and how all of that impacts the treatment delivery and smallest lesion that is treatable in an efficient way. But when we are thinking in terms of big picture, in terms of MLCs and IMRTs, static MLCs or step and shoot, it's a very common term for when the MLCs are moving, but the gantry is not. And these would be static, what we call control points, where each control point is a certain configurations of MLC leaves. So that's static. Dynamic MLC is for a fixed gantry as well, but this time, instead of the MLCs hitting control points and then the machine beaming on, the MLCs are dynamically moving as the beam is on, which is consistently shaping the field. So that part is called dynamic MLC. And if we include gantry rotation into dynamic MLC, then we have something that's called VMAT, or volumetric modulated arc therapy. So that includes MLCs moving and gantry moving. So for fixed gantry angles and static MLC control points, this allows us to deliver radiation from multiple beam angles, and we can sculpt it around the target as seen here, and we can avoid the rectum as seen here. So if we have a gantry moving and an MLC moving, then we call this VMAT. And this is what we call an arc-based treatment delivery. And it could be used with multiple arcs or single arcs. They could be full arcs, so the full 360 degrees, or partial arcs. And often when we get into VMAT and IMRT, and this is a big part of this course, but this is too complex for forward planning. So that is when we use inverse planning to do this. So that's going to be a big part of this course, as well as the inverse planning technique. So just to kind of wrap this up very quickly, I want to do a comparison between a 3D, IMRT, and VMAT. And this is what this table is showing here. So if we look at 3D conformal radiation therapy, we can conform dose and we can spare the OARs, and we can achieve decent treatment time. Here where triangle is the lowest and double circle is the highest. And as we move to VMAT, we can improve conformity on dose and further reduce the dose to OAR. And this also allows us to achieve faster treatment times than 3D if we're careful. So I don't want to say that treatment time is always improved with VMAT, because more complex treatments take longer, but there is a time improvement as opposed to IMRT with VMAT, because the gantry is always moving and you're not having to wait for the individual gantry position as it rotates. So for most of these metrics, IMRT and VMAT are superior, as you guys know. Maybe we can take a break here and see if there are any questions that I can answer at this point, or should we continue?
In static IMRT, are these control points the same ones that can be used for plan QA?
Yeah, so that's a very good question. And I threw the term control point a little bit loosely there. And when we do a plan QA, we're usually QAing the entire plan, which is composed of multiple control points. Think of a control point as it's kind of what the Linac uses, and it's usually based off of a gantry angle. So each gantry angle will have a control point, and then one MLC configuration matched to that control point. So every time there's a new MLC configuration, it's essentially a new control point. And when we do plan QA, we would QA all of the control points in that plan, because that's what we care about. We care about the total dose as opposed to one single control point. But when you're doing like commissioning and further testing, usually like your static field, that's essentially a single control point. If you had something more complex that your MLC shapes were conforming to, then that would just be a more complex control point.
Okay,
Awesome.
great. And there's a good question from Yolandi. Any comments on the number of MU and delivery efficiency? And I think this is actually nice as we're going to get into shielding differences.
Totally. I think that's a great question, and it'll lead us into shielding. And there are a lot of differences in terms of MUs, beam on time. Yeah. So typically IMRT VMAT is higher MU. And that's because, you're not shooting an open field. So you're not delivering that much dose, you're conforming it, and you tend to deliver it in small amounts at a time so that you can deliver it more accurately to shape. Yeah. So we'll come back to that. But going back to what Ben said about being masters of IMRT, I really like the way Ben put that and how he talked about, it's about gaining experience. And at first you don't really know what to look at. So you look at everything because everything seems important. And then eventually, when you master IMRT and you spend a lot of time with IMRT, you notice that there are certain topics that will consistently come up, which impact the success of your clinic. So I've listed some of them here, and they're all important. And let's just talk about them for a minute. So imaging is very important, and it comes up a lot. So treatment planning, simulation, patient setup, those are some cases when imaging comes up. And there's a famous quote that says, if you can't see it, you can't hit it. And I think that really illustrates the importance of imaging, because even though we have this fancy tool and treatment machine, we still have to see what we're hitting and know where we're delivering it. Contouring is very important. Treatment planning, patient immobilization, imaging and treatment, the delivery itself, and then quality assurance. So being a master of IMRT really involves kind of being a master of each one of these specific areas to some degree. And then dose calculation algorithms for accurate IMRT. This is also going to be part of the course, just to give you guys an introduction. And if you look at this plot, which is showing a historical depiction of our dose algorithm based, for a long time, we had correction tables, tissue phantom ratios, tissue air ratios, and these were called correction based. So, back 90s, 80s, that's what was mainly used. But then in the 2000s, collapsed cone convolution, superposition started becoming used more. And then Monte Carlo is starting to be used and to show that it's more accurate. And also, what I'm showing here is that we're trying to solve the particle transport equation. And essentially, Monte Carlo is looking at that. So in this course, we're going to talk a little bit about these dose calculation algorithms, and especially when we have tissue inhomogeneity, what does that look like? So something like lung, bone, or air. And, when we have phantoms, which are heterogeneous. And with those phantoms, we want to make our measurements and test our plans so that we can validate our treatment planning system dose calculation algorithm. So these are some of the things that we'll be talking about. Okay, so I don't want to go too far into the introduction, and I'll just pause there again if there are any questions, but I'd like to conclude the introduction there and then jump into shielding next. So are there any questions?
Yeah, there are a few questions. This is Sarah. So
Hi.
Let's start with that. Hi. The first question was, I think it's an important question. We would like you to briefly explain the difference between forward and inverse planning.
Sure. Yeah. So forward planning generally, it means that you are physically setting the shape of your MLCs or your compensator. You're drawing them yourself because you know what the tumor looks like. So you know that you want to cover that tumor, and then you add some margin. So it is the manual determination of the field shape, whereas inverse planning refers to having an algorithm determine that field shape, that MLC pattern. So with inverse planning, we're not deciding where the MLC leads should go. An algorithm is deciding that. And for the longest time historically, we really wanted to be sure that that algorithm was computing things correctly, which is why our QA procedures around IMRT early on really were very strict because it was a new technique, but also we wanted to make sure that the algorithms weren't computing something nonsensical. And that's why inverse planning and IMRT comes with a lot more QA and patient-specific QA. But without rambling on too much, that's the difference between forward and inverse planning.
Okay, Kevin Mahdi has a question. Why do we use an odd number of fields when we plan IMRT?
So at our clinic, we don't necessarily use an odd number of fields. We don't set any limitations towards even or odd. I'm not sure why there would be a need to use an odd number of IMRT fields.
I think the importance is to spare the beam such that you do not have parallel opposed, right? You do not want two beams exactly opposed to each other. So it might be more that than having necessarily an odd number. Do you agree?
Yeah, it could be that. So that makes a lot of sense. So if you don't have opposed beams, then you don't have the summation of the exit dose from both of the beams adding up to the same area. So maybe instead of odd, maybe like staggered beam orientations so that the exit of one beam doesn't add to the entrance dose of another beam. That makes a lot of sense. Yeah.
Great question is regarding the control points. I think the question was, yeah, he says, could you explain control points briefly? I think like the meaning of control points.
Yeah. And that is just a point in the plan with a certain MLC pattern. So a particular MLC pattern is called a control point. All right. So in the interest of time, we have about maybe 20 more minutes. So I'll move on to shielding. And this is just a note that teaching shielding calculations is beyond the scope of this course. And it's very complicated. And what is often done in North America is a qualified shielding expert is hired when we are designing a vault at our center. So these are medical physicists whose only job is to design vaults and perform shielding calculations. With that being said, I think the importance of this note is that if you are ever doing any shielding survey or vault design, you don't want to do it by yourself. You want to find somebody that has expertise in it and have their help as well. So I think that's really important. All right, so Zoom poll question time. Let's do this one. So why do we need to consider shielding for IMRT treatments, even if the Linac vault was previously used for 3D treatments? So let's say you had a previous vault that you used for 3D and it was a Linac. So same Linac, maybe before it didn't have IMRT capabilities. Now it has IMRT capabilities. And the question is, why do we even need to reconsider shielding if we're going to use the same? Looks like we have about 50% of the participants put in their answer. Maybe we'll wait a couple more seconds. Nice. All right, so it looks like we have about 3/4. Maybe we can end the poll and show the results. Perfect. So the right answer is because IMRT plans have more MUs than 3D plans. So basically, when you have more MUs, your machine is on longer. So therefore, even though you're delivering the same dose at isocenter, let's say, but you're going to have more scatter. There could be scenarios when your primary barrier is maybe receiving a small area of it, that full MU. So that's the prime reason. The other ones, also have something to do with shielding, and those are important to consider, but mainly it's the increase in MUs. So we're going to be running the machine on for longer, is essentially the point. Okay, let me close that. And I'll just go through these a little bit quickly, but in terms of radiation protection, we have to talk about units, and that we're always talking about effective dose as opposed to absorbed dose, which we see in our treatment planning system. And the relationship between absorbed dose and effective dose includes the radiation weighting factor and the tissue weighting factor in it as well. But for surveys, we keep things simple. We measure exposure rate when we're doing, so this is ionizations in air. And the reason why I say we keep it simple is that we say 1 Röntgen is equal to 1 rad or 1 centigrade. Sorry, it's equal to 1 rad, which is 10 millisieverts. So this is what is typically done in radiation survey as a conservative estimate and also an efficient method. So the other thing that we have to keep in mind are our radiation personnel and dose limits. So these are what are going to define the dose limits in our control area, in our control room, in the office next to the vault. So whenever we're shielding, we want to ensure that we meet these recommendations by the state and the country. So all of this to say is it's important to know the recommendations that your clinic follows in terms of radiation workers and public employees. And in addition to the dose limits, there are differences in areas where we have controlled areas. These are areas where we expect radiation workers to be in, and uncontrolled areas, and this is where public will be in there. Obviously, the differences are that for radiation workers or nuclear radiation workers, we monitor the radiation, the total body radiation that they receive, whereas for the public, we don't. All right. So when it comes to radiation safety, the 3 important factors to keep in mind are time, distance, and shielding. So obviously, the longer you're exposed to radiation, the more dose you will be receiving. The closer you are to the radiation source, the more dose you are receiving. And if you are not shielding yourself, then the more dose you're receiving. So let's look at the schematic of a Linac vault, which is very typical. And what it's showing here at the center is the isocenter, or I guess you can think of this as where the linear accelerator would be. And then we have these arrows, which are indicating different types of radiation. But then we have these thicker barriers here. And then we also have this, what we call a maze or a hallway. So the thicker barriers we call our primary barriers. This hallway here we call our maze. And then and then the rest, I guess we can call our secondary barriers, but let's talk about the types of radiation. So the solid arrow, primary radiation. This is, well, I think I'm going to go into each one of those on the next slide. So let me just list all of them. So we have primary radiation. We have leakage radiation. So this is head leakage. So this is a radiation that would come from the head of the Linac. We have scatter radiation. So scatter radiation can come from scatter that's generated from collimators, jaws, patient, the room, basically anything that can cause scatter. It will contribute to it and is part of the scatter radiation. And then photoneutrons. So because our jaws in most linear accelerators are made of tungsten, and the photoneutron activation energy for tungsten is very close to 10 MeV. Energies of 10x or higher. Usually it's why we have to worry about photoneutrons.
It sounds like some people can't recognize which arrows, which is. So do you mind using the pointer, I guess, to explain what you're talking about? Thank you.
I appreciate it. Thank you. Yes. And thank you for Ben for the color coding. Yeah, and I think over the next few slides, it'll be clear. And what I mean by primary radiation is radiation that is coming out of the linear accelerator and might be incident on the wall, like directly. And that's what the red here that Ben drew, that's what it's supposed to show. Perfect. And then, yeah, let me move on to the next slide. Thank you. Okay. And these should be performed, if you have a new facility, so a completely new vault or linear accelerator. If you have an old installation, this is when you would perform this radiation survey. So this is an older Linac, but you're maybe upgrading it or doing something totally new with it. And then new procedures, which is very common in a clinic. You might want to commission a couple of beam energies first for urgency. And then maybe later on, you would say, okay, well, I'm going to commission 15x. Since we don't use it that much, then I'll commission it later. And then for that, when you do that 15x commissioning, then you also should consider your radiation survey. Okay, so very quickly over the instrumentation. So we have a survey meter, which is an ion chamber. and it measures an instantaneous exposure rate. Here's just an example of that. The other survey meter that is important is a neutron detector. So this is important for detecting photoneutrons. And again, right, like here is the activation energies for different materials in the Linac head in terms of photoneutron production. And that's also a very useful survey meter to have. And then lastly, a Geiger-Muller counter. It's not specific to the type of radiation, but it is used to track down if there are any cracks or any leaks. This is a very sensitive device that can help find, any sort of structural cracks in the wall or in the shielding. So all of these equations and calculations and the way that we determine the amount of shielding thickness, it comes from the National Council of Radiation Protection, report number 151. And I believe we'll be able to share with you guys a spreadsheet which gives a breakdown of how most centers perform these calculations. And here is a very low resolution screenshot of that spreadsheet. But what it will have are basically, all of the values that you need to measure, all of the values that you need to take from a reference, and then the equations for computing thicknesses of shielding material and also dose rates. So we want to make sure that you plan your survey, you consider energy, dose rate, and treatment type. And with that being said, if you are going to commission or if you are going to do a shielding survey, you want to make sure that you use the highest energy beam and the highest dose rate. And that is a common way of accounting for lower energies or lower dose rates. We're going to talk about just a little bit about primary, scatter, and secondary barriers. And then there are terms that are important when looking at shielding, such as the workload. So how much is your machine outputting every week? Use factor, occupancy, and I'll get into a little bit of those. Okay, so we have surveys for the Linac head, which I mentioned in terms of leakage. We have an initial survey, which is your primary, secondary, and then you also have a final survey, which you confirm some of the measurements with. So this is what a typical Linac head survey of leakage radiation looks like. And what is typically performed is once a Linac is installed, you would cover the head of it by these large sheets of film. And it doesn't have to be pretty, but you just want to make sure that you're not missing any parts around the Linac head. And what we're trying to do is we're trying to see if there is any sort of internal shielding inside the linear accelerator head, which is inadequate. Maybe something fell off, maybe something fell apart, but if part of the shielding, internal shielding is missing, we want to be able to detect it over here rather than account it by adding more and more shielding to our vault. We want to be able to account that here. And I'll get into each term of this equation, but this equation is from NCRP 151, which comes from us being able to have a primary goal in terms of how much we would like our dose rate to be, how far away we are, and then also workload and usage or occupancy factor. So the way that you would do this is you would wrap the Linac head with film and a number of films like this, and then you would deliver a certain amount of MUs, 1,000 MUs, 300 MUs, but really you want to be able to just see if there are any dark spots that stand out in the films without saturating the films. So most films have a dose limit of about 2 to 5 gray. So you want to make sure that you're not basically saturating the film there. And then you would read the films, and then you can also, if there is leakage, you can place an ion chamber near there to make a measurement. All right, so that was how you would look at leakage from the Linac head. Now,
Tomi, it seems like we might have a question related to what you were talking about. Sumiela from Algeria, I see you have your hand raised. Would you like to unmute yourself? Okay, maybe no question there. And then we did have a question bouncing in the chat. Why can workers receive more exposure compared to the public, at least with the limits?
Radiation workers, so both limits are pretty low. So they're both conservative. The idea is that radiation workers are aware of the risks, and they're choosing to work in a nuclear position. So because they are accepting that additional risk, I have heard, like that's the only explanation that I've heard for why there is that double standard. I mean, like nuclear workers don't have some sort of, radio resistance that the general public doesn't. But the idea is that because you're working in a nuclear field and you are accepting that risk, then that's why it's been raised. Okay, initial survey, primary barrier. So this is the radiation that's directly incident on one of the Linac walls. So when you're making a measurement for primary barrier, you want to make sure that you open up your jaws to maximum. So 40 by 40 centimeters is usually the maximum field size. It can be different. You want to rotate your collimators to 45 degrees. The reason why you do this is because you want to get the diagonal across that square field size, which is the longest. You want to have that span across your wall, and you don't want to place any phantom in front of the beam. And a couple of other things is that you want to measure 30 centimeters away from the barrier, and you obviously want to minimize your exposure anywhere to your badge. So all of this is described in the NCRP 151, and this with addition to this barrier transmission equation, this is what we use to determine the adequate thickness of a certain shielding material, depending on what the material is: concrete, lead, heavy concrete, sometimes dirt, so just soil or the ground is used. But what we want to do is we want to determine the required barrier transmission. And then this will tell us the thickness that we need. So in terms of the number of 10th value layers is equal to, I'm just writing this on here, log BX. So this N is ultimately what you're calculating, and that's your number of 10th value layers that you need to achieve this barrier transmission factor. So you have your weekly dose limit, your distance from isocenter to the wall, your workload, so in dose per week, your use factor, and your occupancy factor. So let's go a little bit into each one of these variables. Oh, I have to clear. Okay, so workload is in dose per week, and this is the maximum amount of dose that you expect to be delivered to a reference point in 1 week. So it's usually in gray, and there is an equation for calculating your workload. It's given here. Just to keep things moving, occupancy factor refers to, for that particular area, how long is a particular nuclear worker or for somebody from the public expected to stay there. So something like offices or nurses stations, that factor is unity, because we're assuming that there's always going to be somebody there. For things like storage areas and outdoor areas, then that decreases. So these are the factors that are recommended for us to use in that equation. And use factor refers to not the area, but the wall. So basically, for that particular wall, like that primary barrier, how often do you think it is being used? And this depends on your treatment. And NCRP 151 gives us values for what use factor to use. And after the primary barrier, secondary barriers account for leakage, scatter, anything that's not primary. And this is when you would place a phantom, when you're making these measurements. For a primary barrier, you don't have a phantom on the couch because you want to measure the primary beam. For a secondary barrier, you do want a phantom on the couch, and it could be solid water, anything really. And the reason is that we want to generate as much scatter as possible to be able to test this. And we pay special attentions to things like physics ports, which I think mean the tunnels between the walls where physicists fish in their cables, their coax cables, but anything else like HVAC and whatnot. And lastly, neutron shielding. So I mentioned neutron shielding, the photoneutrons that are generated. We want to make these measurements at the end of the maze, and we want to make sure that neutron shielding is adequate as well, especially for higher energies. And I mentioned controlled versus uncontrolled areas. There are also other aspects, things like sky shine, which refers to radiation being scattered off of the atmosphere and coming back down to the general public, which could increase dose, and also ground shine. So radiation scattering off of the ground and being missed by our shielding material, and then that contributing to dose. So there are also those components. But in conclusion, I would just like to emphasize safety tips, which I think are important for Linac surveys. And then essentially we're checking, I think something that's important is equipment functionality. And by this equipment, I don't mean the linear accelerator, but I mean our survey meters. So it is recommended that any survey meter is calibrated or cross-calibrated at least once a year. So it's really important to at least have confidence that your equipment is functioning properly. So I think that's really important. Whenever you're doing calculations or surveys, you want to build in a lot of redundancies. So more than one survey meter, more than one person. A radiation safety officer is somebody who is assigned to radiation safety. Having a radiation safety officer is also a good idea. And then have an idea of what to expect is just in terms of making a plan. So having that spreadsheet, having the floor plan, before you go out to make any measurements, just kind of understanding what you're looking at and what your goals are, and then be thorough in terms of thinking about, worst case scenarios or what needs your clinic can have in the future. And you want to be able to, not want to go back and have to add more shielding to your vault. So ideally you do the shielding survey once, and then that is adequate. So here are some references, and with that, I'd like to thank you for your time.
Thank you, Tomi. We have a few questions. There's I think, a legitimate question about the occupancy factor and the use factor. I guess the question says, where do they come from? On what basis? I guess maybe we can explain briefly what is occupancy factor and what is use factor. That was followed by another question asking about occupancy factor for an elementary school, which I'm not sure. And I've never come across that before, because typically elementary schools are not mixed vaults. So I don't know if you have
Yeah, so these numbers come from NCRP 151. And I don't remember off the top of my head particular reasons as to why these values were chosen, but you can tell that they are chosen a little bit arbitrarily with experience and based off of empirical data that they have. For occupancy, I think the idea is we always tend to be more conservative with shielding. So, full occupancy areas, these are areas that 100% of the time somebody could be there. So we assume that all of the dose is going to the patient. Maybe the other ones, I think these are just kind of estimates that others have made. And same thing with this use factor. Like, this depends on a lot of things. Like, if you're only doing VMAT full arcs, then the use factor for all of the walls is like the primary walls that the gantry can see. Those are all the same, and they should be a factor of what each one of them represents. But not all plans are VMAT, not all plans are full arcs. You have step and shoot, you have other plans. So I, again, don't remember how NCRP came up with these values, but they have usage factors for different walls as well. And I think it's described in there.
Thank you. Sonia Ayed from Algeria has been asking if there are any other documents similar to NCRP 151 that's not NCRP, or whether everyone uses NCRP. I don't know. I think typically use NCRP, right? Reports. I haven't heard of any other documents. Shielding calculation. Have you?
About TLDs or?
Shielding, for shielding calculations. Have you used any other document other than NCRP 151?
I've only used NCRP 151.
Okay, that's what I've done. Me too. It sounds like some are asking if there's an Excel sheet I guess that you could use to calculate, like for shielding calculations. Do you have any?
Could you repeat that question?
Is there any Excel sheet that we can share with others? It looks like some people have asked about Excel sheets, if there are any.
Yeah, I think we do have one. Ben, do you have any more information about the Excel sheet?
Yeah, if we are able to make one, because we see that a lot of people are interested in it, we will reach out to you. We will send it to everyone if we are able to make one.
Okay. Someone is asking about decommissioning process of 15 MB Linac. You need to have attention in building materials on Linac head. I'm in the process of decommissioning Arlene. I haven't done it yet, but my understanding is all we need to do is survey the room basically prior of the removal of the Linac, and then you just survey afterwards. And ideally, you shouldn't measure any radiation, right? So to the best of my knowledge, there is it. Sorry.
Yeah, that sounds.
Not sure who's talking. Okay, that sounds good. Okay, many thanks to you. Okay, until we find that question, because this is like
yes,
this is a question.
Yes. Hi, Saif.
Yes, Dr. Ben. I think it is unnecessary to do a safe area after primary or wall, after bunker, in the side of public area.
I see. Is it necessary to do a safe area after the primary barrier wall of the bunker on the side of the public area?
Yes.
Yeah. So it depends. It depends on the vault design. So for example, you can use maybe less shielding, and then you have a safety area, and then you perform your measurements outside of that safety area. But often, I haven't seen a lot of safety areas around a bunker, and mainly because like most hospitals, space is tight, and you usually don't have the flexibility to have, to block off an area and say, don't enter this part. What is commonly done that I've seen is as opposed to a safe area is people will use dirt and will mount dirt along a certain wall that maybe they don't want to add more shielding material, but they also don't want people to access that area or that wall. So by adding dirt and then you cover it, it adds additional shielding, and then it also prevents that area from being used. So I've never really seen like a blocked off area that says, hey, no entrance in this zone, but I have seen things like that done outside of a bunker to accommodate for the radiation shielding.
Yeah, and if I were to build off of that, I think really one of the main takeaways from this presentation is you have your vault with your Linac. And if you have been doing mostly 3D conformal treatments, and now you've transitioned to IMRT has a lot more MUs. And so you may need to check to see, hey, is the shielding that I have adequate now that my machine is producing more MUs? And so, you'll have your shielding, and then you'll have your public area on the other side. And I think you'll want to reassess your calculation and say, hey, is it still safe? Is it still safe over here? And if you find that it's not, you may need to take action, as Tomi is mentioning.
Yeah, and I was looking at the chat and I noticed somebody was wondering, why does IMRT use more MUs than 3D conformal? And the reason being because you're sculpting the dose. So it ends up being the dose is being delivered in smaller fragments. But each time you deliver a fragment or a control point, you're delivering MUs. So if you had an open cutout, that single MU would be that dose would go through the entire area. But now that you have an MLC, and it could be, instead of using my hands, let me just show you. I guess I had that GIF, like basically, if this entire area was open, let me annotate. If you had a cutout that was just a square, and then you delivered 1 MU through here, this entire area is going to be receiving 1 centigrade if your machine was calibrated for 1 MU 1 centigrade. But with IMRT, our opening is a bunch of these small, like where the white part is. So therefore, we have to deliver 1 MU to this small part, and then another MU to this other small part, and then another MU to the other small part. And as a result, our MU per dose increases, and it goes a lot higher.
And building on that also, there's a question that's been asked numerous times. It says, please tell us why not use high energy, basically 10, 15, 23, whatever MV for IMRT or VMAT. So I don't know if you want to follow up.
Yeah, and it's essentially the photon neutron production that limits a lot of the uses for us. So yeah, very rarely do we use 15 or 18, only for very deep-seated tumors, and maybe with if you can
So that
only
you can
enter,
achieve a reasonable results, right, with 6MB.
right. Yeah, definitely.
Okay, another question is regarding patient-specific Q. So the question is back to IMRT. They have matrix phantom, and they would like to do a QA for large PTV, such as, and they're asking how can they do that? Basically, they split right and then shift the phantom, I guess.
Yeah, I know. Is Matrix Sun nuclear? I can't remember, but I know
No, Matrix.
maybe like a lot of the software, I know Sun nuclear software has this flip capability where you can measure, one part of the plan with your detector and then flip the detector. So you just kind of like rotate it to measure the other part, and then the software will stitch them together, like based off of assuming your setup, and then it'll give you a full dose plan. So if I understand correctly, something like that is done regularly. But that's a good question for the patient-specific QA module, and I'm sure they're going to go into that and go into more detail. But that's a great question. Yeah, so those are one of the important questions. Maybe we can stop it there if I'll stop sharing.
Yeah, great. Thank you so much, Tomi. Wonderful presentation, and thank you everyone for bringing your questions.